Good morning, and thank you for joining us. My name is Karen Curtis, and I am a member of the Provider Outreach and Education team here at WPS. With me today is Ashley Dakota. She is going to be helping me by watching the chat for any questions or issues you may have, as well as providing information and links when needed. Today, I am going to be covering Medicare wellness visits. This includes the initial preventive physical exam as well as the annual wellness visits. Now, my goal today is to improve your knowledge in regard to the coverage criteria and billing requirements for the initial preventive physical exam as well as the annual wellness visit. Now, if you are looking for in-depth information regarding documentation, our coworker, Jennifer Boniface, held a webinar last month that was titled Navigating the Ins and Outs of Annual Wellness Visits. A recording of her webinar can be found on both our website in the Encore and short video webpage, as well as the YouTube channel. Now, I'm going to be covering coverage criteria for the IPPE and the annual wellness visits, the components of each exam, billing requirements, and common errors and resolutions. So let's begin with the coverage criteria. Now, in the Medicare world, when we talk about physicals, there's 3 exams that most likely come to mind. A routine physical exam is a visit that is not related to a specific illness, symptoms, complaint, or injury. This could also be exams that are referred by third parties, such as employers or insurance companies. And this form of a physical exam is not covered by Medicare. The initial preventive physical exam is for beneficiaries who are new to Medicare. This is often known as the Welcome to Medicare preventive visit. And this exam is done within the first 12 months of entitlement. It's to promote good health and disease prevention by reviewing the patient's medical and social history. Since the patient is new to Medicare, this is also a good time to discuss the different preventive services that Medicare covers. The annual wellness visit is an exam that occurs after the initial 12 months of Medicare entitlement. The goal is to provide recommendations which help patients live a healthy life. This can include developing or updating a personalized prevention plan and performing a health risk assessment. And we're going to start with a couple of the requirements. The IPPE should be performed by a doctor of medicine or osteopathy. The service can also be performed by a qualified non-physician practitioner. The Code of Federal Regulations states that for the purpose of an IPPE, a qualified non-physician practitioner refers to a physician assistant, a nurse practitioner, or clinical nurse specialist. This exam should also take place within 12 months from the date that the beneficiary was entitled to Medicare Part B. For coverage criteria, the IPPE is covered under Medicare Part B. Coinsurance and deductible are waived for the actual examination, but they would apply to the electrocardiogram if that is ordered. This is a once-in-a-lifetime benefit, and it should occur within 12 months of the Medicare Part B entitlement date. Requirements for the annual wellness visit. Exams should be performed by a health professional. I've listed some examples here. I do want to provide a little bit of clarification on that third because of questions that I've received in the past. A licensed practitioner is a person who is licensed by the state and is qualified to provide care, treatment, and services. Direct supervision means that the physician or non-physician practitioner who is billing Medicare for the service must be present in the office suite and immediately available to provide assistance and direction during the time the service is being provided, but they do not have to be directly in the room. Medicare also requires that at least 12 months have passed since the patient became entitled to Medicare Part B. They also must not have had an initial preventive physical exam or an annual wellness visit in the 12 months preceding the current exam. Now, the annual wellness visit is covered under Medicare Part B. Services should be provided at least 12 months after entitlement. And again, the patient should not have had an annual wellness visit or an IPPE within the last 12 months. The exams should be performed by a health professional. Copays, coinsurance, and deductibles are waived. This is also true for advanced care planning and the physical risk assessment, which we'll take a look at later. Now, annual wellness visits are covered once every 12 months. And what this means is that 11 full months must have passed starting from the month after the service is received. For an example, if a beneficiary received an annual wellness visit in January of 2026, you're going to start counting the 11 months beginning in February. So that means that the patient would be eligible for their next visit in January of 2027. You'll also want to make sure that 11 full months have passed since their IPPE. So same thing, if they got the IPPE in January of 2026, you wouldn't want to perform an annual wellness visit until January of 2027. Now, each of these exams have different components. Some are required while others are optional. So let's take a closer look at those. And we're going to start with the IPPE since this is the first exam that Medicare beneficiaries are eligible to receive. So first, you're going to want to talk to the patient about their medical and social history. Find out if the patient has any allergies or illnesses. Are there past surgeries or hospital stays? This is a good time to discuss the health of the patient's parents and siblings. That way you can identify conditions that could be hereditary, and this is going to allow you to develop a plan and how to provide the best care for each individual. You'll also want to determine if the patient is currently taking any medications or supplements. Is the patient physically active, and do they get involved in social activities? It's been found that individuals that have strong social connections have lower health risk for health conditions such as heart disease, stroke, dementia, and depression. Establish what kind of diet the patient has. Are they eating a balanced diet or are they relying on fast food? Lastly, discuss the use of alcohol, tobacco, or illegal drug use. Review the patient's depression risk factors. This would include past or present experiences with depression or mood disorders. There are a variety of standardized screening tools which can be used. The Medicare Wellness Visits webpage does have a link that can provide you with available instruments that can be used while conducting that depression screening, and I have included a link to that on the resource slide. Review the patient's functional ability and safety level through direct observation or screening questions. Is the patient having problems with daily living? Are they still able to access all areas of their home? As people age, steps can become harder to navigate. Ask if they've fallen recently. If yes, does it occur frequently? This could lead to a discussion as to whether the patient needs assistance from family or caregivers, or, can they continue to live in their current living situation? Assess the patients for hearing impairment. Um, perf Perform an exam. This is going to consist of taking measurements such as height, weight, body mass index or waist circumference, blood pressure, balance and gait. A visual acuity screening is also included in that. If the patient agrees, end of life planning can be discussed. This discussion can include advanced care directives and helping beneficiaries fill out legal forms if they wish. Um, some examples would be a living will, medical orders for life-sustaining treatments, durable powers of attorneys, things like that. If the patient has an opioid prescription, uh, screen for any opioid use disorders. Evaluate their current treatment plan to see if any changes need to be made. Maybe they could switch to a non-opioid treatment for pain management. Screen for any substance use disorders and refer to treatment when appropriate. Provide personalized health advice and referrals. Take in all the information that you've gathered and provide education based on your findings. Maybe the patient could benefit from one of the other Medicare preventive services, such as diabetes or glaucoma screening. Depending on the identified risk factors, maybe they need counseling for smoking or alcohol misuse. Lastly, provide a brief written plan for the patient. This can include an optional screening electrocardiogram and other appropriate services. For the annual wellness visit, not every visit is going to be the same, but it shouldn't always include a discussion regarding the patient's individual and family medical history. You're also going to want to include routine measurements such as height, weight, blood pressure, things like that. For the initial visit, discussions may be more detailed because you're trying to establish a general idea of the beneficiary's health. Is the patient at risk for certain illnesses or disease? Are they eligible for other preventive services? Are there risk factors that need to be addressed? On this slide, I have listed CMS requirements for topics that could be covered in the first annual wellness visit. One of the first is to perform a health risk assessment or an HRA. I am going to cover this topic in a little more detail in just a few minutes. You'll also want to establish medical and family history. So we talked about this with the IPPE. See if there's any allergies or illnesses, surgeries, hereditary diseases, things like that. Obtain a list of providers and suppliers who are regularly involved in the patient's medical care. Collect measurements. Check for cognitive impairment. Now, with this, some factors could be harder to evaluate. So while tests can determine if the patient is experiencing a loss in vision, you may not know if they're having memory issues or changes in behaviors. Now, providers may be able to obtain additional information if the patient is accompanied by a family member, friend, or caregiver. This cognitive assessment can be used to detect signs of dementia, depression, or anxiety. Review depression risk factors. Again, there are some tools listed on the CMS website that can help you with that. Review the patient's functional ability and safety level through direct observation or screening questions. Is the patient having problems with daily living? Are they experiencing pain or fatigue? This can all lead to discussion as to whether the patient needs assistance. Establish a written screening schedule for the patient to follow. The Medicare Preventive Services tool is on the resource slide. It has a link for a checklist that would allow beneficiaries to track preventive services. If we have time, we'll take a look at that later. Establish risk factors and conditions that could lead to development of chronic disease. So things like physical activity, nutrition, tobacco and alcohol use. Provide personalized health advice and referrals if appropriate. If the patient is open to the topic, you can also discuss advanced care planning in these situations. This is a service that can be billed separately, so we will look at that a little bit closer. Again, if the patient has an opioid prescription, you're going to want to screen for opioid use disorders, screen for substance use disorders, and refer treatment if appropriate. And then lastly, an optional physical activity and nutrition risk assessment can be performed. The physical activity assessment is going to assess the patient's exercise level and fall risk. The nutrition risk assessment is to evaluate the patient's daily caloric intake, their diet, and hydration. This I will cover in a little bit more detail also. Now, during subsequent visits, you're going to want to review and update those components of the initial annual wellness visit. A lot can happen in a year, so you'll want to make sure that your records are up to date. Some patients may be seeing multiple doctors, so you'll want to see if there's been any changes to their medical history. Did another physician add medication to their daily routine? Have they been referred to any new healthcare providers? And then again, you'll take those routine measurements. You'll also want to update the personalized prevention plan of services if needed. Um, Review opioid prescriptions again and substance use disorders. And then they'll also cover in these subsequent visits advanced care planning if the patient's interested. And then you can also conduct that optional physical activity and nutrition risk assessment. Now, I do want to talk about the health risk assessment in a little more detail. The Center for Disease Control reports that 6 in 10 Americans live with at least one chronic disease. Um, they are the leading driver in healthcare costs, and they often are caused by changeable risk factors. They've also determined that there are many patients who do not receive recommended preventive services and follow-up treatment. So the HRA is an opportunity to receive self-reported information. It shouldn't take more than 20 minutes to complete. Some of the information collected in the HRA does overlap other areas of the annual wellness visit, but it also includes demographic data such as age, sex, and race. You want to ask the patient how they perceive their health. This can help you determine what type of education they need regarding their own healthcare needs. Psychosocial risk can go along with reviewing depression risk factors. Does the patient experience a lot of stress, anger, or pain? Are they lonely? How satisfied are they with life? Some behavioral risks are covered when reviewing opioid prescriptions and screening for substance use disorders. Topics of conversation can also include physical activity and nutrition. Does the patient visit a dentist on a regular basis? Do they wear their seatbelt when driving or riding in a vehicle? Ask if they can perform activities of daily living. So this can include things like getting dressed, feeding themselves. Can they get around well? Are they able to prepare their own food or, do some light house cleaning? Now, if they're no longer able to drive, do they have a reliable resource for transportation? If they're prescribed medication, are they still taking them? Things like that. One of our clinical workers did just add a resource to the WPS website, which provides components of the assessment. Um, she talked about common issues that were identified by our medical review department and best practices for providers. I will have actually add that link into the chat in case that's something that you're interested in taking a look at. At the bottom of this slide, there is a link to the CDC report on the HRA. It includes methods that could be used and recommendations. Now, advanced care planning is a chance for a patient to prepare in case of an injury or an illness that prevents them from making their own healthcare decisions in the future. This portion of the annual wellness visit is voluntary and it should be done face-to-face. This discussion may be with the patient, a family member, a caregiver, or a surrogate. Part of this discussion may include advanced care directives and helping beneficiaries fill out legal forms to make sure that their wishes are carried out down the road. Um, I've listed some examples here. A living will and medical orders for life-sustaining treatment will allow patients to make decisions regarding what medical treatments they would like or what medical treatments they don't want to be used to keep them alive. Maybe the patient wants to assign someone that they trust a durable health power of attorney so that they can make those decisions. The Psychiatric Advance Directive allows a person with a mental illness to make their wishes known prior to an emergency. There are two parts to this, and beneficiaries may include things like um, healthcare or childcare instructions or contacting an employer. Those kind of things can be included in it. If the power of attorney is added, it can be used for both medical and psychiatric emergencies. And a lot of these forms can be found on your state's Department of Health website and also sites such as the AARP. Now, the physical activity and nutrition risk assessment is something new this year. This is an optional component of the annual wellness visit, and if performed, providers must follow standardized evidence-based practices. I've included some examples here, but the CMS webpage for annual wellness visit does include links to assessment tools that can be used. Information gathered during these assessments can be used to make medical decisions, guide treatment, or provide suggestions for preventive care. So now that we've looked at the coverage criteria and the components of those exams, I want to move on and I want to look at how the claims should be submitted to Medicare. Now, when submitting claims to Medicare for the IPPE, you're going to want to include code G0402. Codes G0403 through G0405 refer to the once-in-a-lifetime screening EKG that can be performed if appropriate. During the initial exam, the provider may discover symptoms or risk factors that could lead them to believe that an EKG would be beneficial. CMS does not require a specific diagnosis code to be billed with the service, but the code should be consistent with the patient's exam. Now, if you are a provider who submit claims on a CMS 1500 or an 837P, the type of service listed for the IPPE should be a 1, and the codes referencing an electron would be billed with a type of service 5. Claims submitted on a UB04 or an I would need to include a type of bill from one of the facilities shown here. RHCs or FQHCs who bill under the all-inclusive rate, which is also known as AIR, payment for the professional services will be included in that AIR payment. Charges should be sent on a type of bill 71X or 77X, depending on your type of facility. Claims should include the appropriate site of service revenue code in the 520 series and must include HCPCS G0402. If an optional electrocardiogram is performed, the professional component is included in the AIR rate and it is not separately billable. For FQHCs who bill under the Prospective Payment System, or PPS, HCPCS G0468 may be billed using an appropriate site of service revenue code in the 52X range. G0468 is used when a visit includes an IPPE or an annual wellness visit and a typical bundle of Medicare covered services that would be furnished per diem. The Medicare claims processing manual publication 100 100-4, Chapter 9 does provide payment examples for claims that include HCPCS G0468 along with other services. So if that is something that you're interested in, I just wanted to let you know that they do provide examples for you to look at. Now, if you are an OPPS hospital billing on a type of bill 12X or 13X, CMS has provided special instructions when the technical component of the electrocardiogram is billed on the same claim as the IPPE. You will want to make sure to include modifier 25 when submitting HCPCS G0402 along with HCPCS G0404. This will help avoid edits that could be received by the outpatient code editor. Now, for annual wellness visits, when submitting claims to Medicare, you're going to want to use code G0438 for a beneficiary's initial annual wellness visit, and then subsequent visits are going to be billed using code G0439. There is no specific diagnosis code required when billing for the annual wellness visit, so you will want to use a code or codes that are consistent with the patient's exam. The type of service code should be a 1 for providers who bill on the CMS 1500 or 837P. Because G0438 is specific to that initial visit, it is considered a once-in-a-lifetime code. The recovery audits contractor has reported that they have seen providers billing this code more than once. I'm not sure if that's due to patients seeing different providers or if it's a misunderstanding of which code should be used. The second code listed, the G0439, can be billed annually. Now, if you're a provider who bills on a UB04 or 837I, I've listed the type of bills that can be used when billing for the annual wellness visit. You can see that the services can be performed in a hospital, skilled nursing facility, rural health clinic, federally qualified health center, or a critical access hospital. Now, if you are a Method 2 critical access hospital, you can receive payment for the annual wellness visit professional services in addition to the facility payment. Charges for those services should be billed using the appropriate revenue code listed on this slide. For rural health clinics and federally qualified health centers, the professional portion of the services should be billed using type of bill 71X or 77X. Claims must include code G0438 or G0439, and deductible and coinsurance do not apply. Federally qualified health centers do have an additional option of billing that G0468. And again, that's going to be billed when the annual wellness visit and a bundle of Medicare covered services that are furnished per diem are received. This should be billed with the appropriate 52X revenue code. If advanced care planning was provided during the visit, you can bill using code 99497 and 99498. No specific diagnosis code is required, so you'll just want to use a code that is consistent with the patient exam. Coinsurance and deductible are waived if it is performed on the same day and as the annual wellness visit. Um, Charges must be billed on the same claim, and it should include modifier 33. And while there is not a limit to the number of times that you can report advanced care planning for a particular patient, deductible and coinsurance will apply if it is provided outside of a covered annual wellness visit. If the service is provided frequently, then you'll want to document what changed in the patient's health status or what decisions regarding their end-of-life care has changed. Now, for those who may have billed annual wellness visits in the past, you may remember that HCPCS G0136. It was the same one that was used to build the social determinants of health risk assessment. Earlier this year, that description was changed to the physical activity and nutrition risk assessment. If this component is completed, you'll bill using that code G0136. The diagnosis code should be consistent with the patient's exam. The risk assessment is covered once every 6 months. While it is considered a component of the annual wellness visit, it can be performed on the same day as an evaluation and management or a behavioral health service. Coinsurance and deductible are waived if it's performed on the same day as the annual wellness visit. Charges must be billed on the same claim with modifier 33. For assessments performed during an annual or during an evaluation management or a behavioral health service, then deductible and coinsurance will apply. Also, if the annual wellness visit is denied for frequency, then coinsurance and deductible will apply to the risk assessment. Now, there may be times during a wellness visit when a problem or an abnormal finding is significant enough that it warrants performing a problem-focused evaluation and management. The evaluation and management must be performed on the same day as the IPPE or annual wellness visit. It should be separately identifiable, medically necessary, and related to treatment of an illness or injury or to improve the function of a malformed body part. When determining which code is appropriate, services that were provided as part of the annual wellness visit, such as reviewing the patient's medical history or routine measurements, should not be included in the decision-making process. Modifier 25 should be included on the line containing the evaluation and management code. So I want to take some time and I want to look at common errors that these wellness visits receive and how you can either fix them or avoid them. I want to start out with some RAC findings. For those of you who may not be familiar with the Recovery Audit Program, their job is to identify and correct Medicare improper payments. This is done by conducting both manual and automated reviews of post-payment claims. So when the RAC performed reviews on initial preventive physical exams and annual wellness visits, they found that the initial annual wellness visit, which was HCPCS code G0438, was billed more than once per lifetime. They also found that it was billed sooner than 11 whole months following the initial preventive physical exam. There were also some incorrect coding issues that were found. Code G0402, which is for the IPPE, the RAC found that this service was billed more than 12 months after the Part B entitlement date. It was also found that this service was being billed more than once in a lifetime. Code G0438, which is for the initial annual wellness visit. So once that service is billed, additional wellness visits would need to be billed using that G0439 for subsequent visits. They found that the G0438 was being billed more than once in a lifetime. And then the code G0439 was being billed within 12 months of another annual wellness visit. Now, I was also interested in what denials we were having here at WPS. So I pulled data on the codes covered in this webinar and found the top denials and rejections were due to lifetime maximum reached, which was also one of the RAC findings. Beneficiaries has coverage through an employer group health plan, duplicate charge, preventive exam not within 12 months of Part B entitlement, which was also reported by the RAC, and collection for service during a period of managed care, and then expenses incurred prior to coverage. Now, to avoid lifetime maximum rejections, providers can perform a preventive services inquiry. If you are registered for the SecureNet Access portal, the patient eligibility check contains a tab for preventive services, and here you can find information regarding preventive services that are subject to frequency limitations. At the bottom of this slide is an example of what is shown for annual wellness visits. So you can see that it has the code G0438 and the G0439. Now, if the patient had that initial annual wellness visit, that G0438, you're not going to see that code on there. So you would just see the G0439 and then that next eligible date. HETS, this is the HIPAA eligibility transaction system, and this is managed by CMS. This option involves submitting electronic files, which will provide you with eligibility data. When I went through the companion guide, I only found data regarding the IPPE, so I couldn't find where the annual wellness dates would be provided. Another option is you can ask the patient. While the patient probably wouldn't know if they received an IPPE versus an annual wellness visit, they might be able to tell you if they received a physical exam, and then that could maybe prompt further investigation to determine like what they actually had. MSP denials are always high across the board. Some ways that you can determine who is primary is by using an admission questionnaire. The internet-only manual, CMS does provide a sample questions that could be used. And this is in the MSP manual, so that first resource that you see right there. While they don't require providers to use their questions, the way I see it is they've already done the work for you. The WPS portal and HETS are also resources that would provide you with this information. I've also, along with the IOM, I've also included a couple resources that are specific to MSP. The first one is a booklet that goes through the different types of insurance plans and who pays first. And then that last resource is a CMS fact sheet that focuses more on how to bill MSP claims. I did want to show you an example of the Medicare secondary payer tab, patient's eligibility check. This is what information can be found. You can see that it gives coverage dates, insurers' names, the type of insurance, as well as the policy and group numbers. If there's a specific diagnosis code that's related to the insurance, for example, if they have workers' comp, then you would find that diagnosis code under the codes header. So kind of has all of the information you need in one spot. For duplicate charges, these can be avoided by checking claim status on our portal or IVR. If you're a provider who bills using FISC, the Fiscal Intermediary Standard System, so this is for Part A providers who bill on a UB04 or an 837I. You can log into DDE to check claim status. I've also included a WPS resource titled Common Claim Denials, and that provides some tips and actions that can be taken for duplicate rejections. Services not within 12 months of entitlement. To avoid this denial, you will need to use a tool that will allow you to verify the patient's entitlement date. The WPS portal does provide this information. You'll see on the screenshot on this slide that I have the Part B effective date highlighted. You could also use HETS. Some providers use billing agencies or clearinghouses, and they can provide you with this information. And then, of course, this information would also be listed on the patient's Medicare card. Collection for fee-for-service during periods of managed care. Billing Medicare with when the patient has an HMO is another common rejection that we see. The WPS portal and HETS can provide you with managed care plan information. So here I've included what can be found in the secure portal. You can see that it gives you enrollment and termination dates, as well as the name of the plan, along with their address and a website link if available. Expenses incurred prior to coverage. This can be resolved again by verifying the entitlement dates. So this can be done through a portal, through HETS, through a billing agency or clearinghouse. And you can also verify entitlement with the patient's Medicare card. Now, I have provided some resources to help with billing the initial preventive physical exam and the annual wellness visit. The first resource is a great resource for any preventive service. It'll provide you with procedure codes along with ICD-9 codes if required. It'll let you know coverage requirements, frequency limitations. Let's go out and take a look because it does provide you with a lot of additional information. Ashley, can you verify that you can see the Medicare Preventive Services tool?
Yes, I can see it.
Okay, thank you. So let's just take the annual wellness visit, for example. So it gives you the HCPC codes that can be used. It gives you the CPT codes, ICD-10, coverage, frequency. One thing I do like down here in the other notes, it gives you links for other resources that can be helpful. The Medicare Wellness Visit, this is the second resource that I provided, and this does have a lot of information for the annual wellness visit and the initial preventive exam. I do want to call your attention to the annual wellness visit just because I get a lot of questions about what it includes. It lists the components for the first and subsequent exams. It gives you details of the elements for each of those tasks or each of those the action that you want to perform. I will tell you that if you see this right here, at a minimum, collect this information. I have been in contact with our medical review department, and this is what they look for. So if it says at a minimum, collect this information, they're going to be looking at your documentation to make sure that you touched all of those. I know a lot of times with the activities of daily living or the instrumental activities of daily living, I have been told that some providers may have kind of a self-assessment that they have beneficiaries or patients fill out that way that they're not going through every single one of these. Or they could document things like patient doesn't need help with the activities of daily living. But I did want to call your attention to that because I have been told by medical review that they do check for those. The Medicare Wellness Visits webpage, that's the one that we just looked at. And then the last three resources are to help you get connected to the system, either through the WPS Secure Portal, DDE, or HETS. So if you're not connected with any of those, that would give you help with getting hooked up so that you can see all the information that we have to offer in the system. Now, before I ask Ashley if any questions have come in through the chat, I did receive quite a few pre-submitted questions, so I would like to cover those first. The first question I got is, what is the difference between a CPE and an AWV? So when I look up the definition of a complete physical exam, I get that the CPE is a hands-on head-to-toe medical exam used to diagnose immediate health problems. An annual wellness visit is more focused at looking at the patient's current health and risk factors to determine how to prevent disease or illness. So the complete physical exam isn't really terminology that I've heard much in Medicare, but that's kind of more of this, there's something wrong and I need you to diagnose this, where the annual wellness visit is more like overall health. I did get quite a few questions on documentation. So documentation is a topic that is covered by our coworker, Jennifer Boniface. And although I have taken a break from doing preventive services webinar, Jennifer does still cover these topics from a clinical aspect each month. So if you want to know more about documentation and what medical review is looking for, I would suggest looking at her webinar that was mentioned at the beginning of today's presentation. My next question was, is a health risk assessment questionnaire required separately to the EHR? So if we look at the CMS webpage for the annual wellness visit, let me see if I can get that back up here. So it does list specifically, like at a minimum, collected information. So it has the demographic data, the health status self-assessment, psychological, psychosocial risks, behavioral risk, ADLs, and IADLs. So you will want to make sure that that is somewhere in the patient's record. Like I said, that is going to be what medical review is looking for. So you'll want to make sure that's in there. What is the difference between an annual wellness visit and a regular evaluation and management visit? An annual wellness visit is to evaluate a patient's health and risk factors and provide a personalized prevention plan to promote wellness. An evaluation and management visit would be when the patient is coming in with a specific complaint or concern. The next question I got was, do you have to bill for G0402 and or G0438 before you can bill for G0439? Now, I am not aware of any system edits that would cause a claim to hit if those HCPCS codes were not billed in that exact order. There are frequency edits that we talked about based on entitlement dates for that 11 full month. But as far as are there any edits that's going to stop a claim if it's not billed in that exact order, I am not aware of any of those. The next question I did receive, I guess, a couple questions about Medicare Advantage plans and reporting the IPPE and the annual wellness visit to Medicare and how to determine eligibility. WPS does not receive notifications of services when they are billed by a Medicare Advantage plan. These claims are through private insurance companies and they're not submitted to us, so there's really no way for us to track what services the beneficiary received through that MA plan. If you use the portal or HETS to determine that you this or MCS, and since that's like a government-owned system, there's just no way for us to track what the Medicare Advantage plan has done. Next I got, is there criteria for charging an evaluation and management with every annual wellness visit service? Evaluation and management service as well as significant and separately billable. It also needs to be documented within the patient's medical records. So the evaluation and management portion of the visit should be treating a patient's illness or injury or to improve the function of a deformed body part. So you'll just want to make sure that you meet the criteria, like you're actually meeting the criteria of what an evaluation and management visit would be. I received a question about chronic care management. There was a word, I wasn't exactly sure what the participant wanted to ask. Chronic care management is a separate topic, and WPS does have a playlist on their YouTube channel that's dedicated directly to that subject. There were also a couple webinars that were held at the end of June on that topic. So those are available on our Encore and Short Videos webpage. Next, does the provider have to add or remove diagnoses from the patient's problem list and medical surgical history as part of the Medicare wellness visit? Um, this is not a Medicare requirement, but if the patient is being referred to other services, you would probably want a diagnosis or a history that would back up that decision. That's just an opinion. That's not a requirement from Medicare. The last pre-submitted question I got was, can the G2211 be billed with other G codes during the wellness visit? I'm going to have actually add a link into the CMS did develop an FAQ. That FAQ document said that G2211 is allowed when the outpatient office evaluation and management base code is reported by the same practitioner on the same day as the annual wellness visit. That was all I got for pre-submitted questions. And since I do see that we are running short on time, I want to respect your guys' time. Any questions that have came through in the chat that I didn't get answered, I will send out a document, an email to everybody that's in attendance today, and I will get answers to those questions for you. A couple of things that I want to cover before I let you go. WPS does receive a lot of overpayment notifications and refund requests from providers. There have been some issues with the overpayment notification refund form that is causing some delays. So if you're able to avoid unnecessary holdups, using the SecureNet Access portal, the refunds or the overpayment claim features are the most efficient. But if you do send a paper request, please be sure that you select the correct contract based on your provider number and the correct Medicare type. For that Medicare type, you're going to want to choose Part A if the claim was processed through FIS and Part B if the claim was processed through MCS. I also want to let you know that CMS is holding an in-person event focusing on Medicare fee-for-service claims, documentation, and compliance. At this time, registration is closed due to capacity limits, but you can put your name on a waiting list. So I at least wanted to let you know, because if you want to get your name out there, you have till July 23rd to do that. The National AB-MAC Ambulance Provider and Supplier Coalition meeting is being held on September 16th. The MACs will present information on current active medical review, ADRs, and the CERT program. Registrants have the opportunity to submit questions ahead of time, but there's also going to be a live Q&A session. So if you're interested in that, that'd be something that you would want to go to. Now, when you disconnect from the webinar, you will be redirected to a CMS survey. I'm also going to have Ashley add a link in the chat. I really do hope that you'll take a moment to provide on how I did today. If you're watching this video as an encore, you're going to see a pop up at the end that's going to appear at like that picture that says survey. The redirect looks like what you see over on the right with the exclamation mark over here. We don't have control over how this looks, so we just want you to know it isn't spam or anything malicious. And the feedback that we get really does lead to changes. One of the changes is holding Medicare education expos based on future education topics. We're currently planning a fourth one to be held in September, so be sure to watch out for the details for that. Now, after you disconnect today, you should receive a thank you for attending email. It's going to contain contact hours that can be submitted for continuing education units. If you joined only by phone, WebEx is not able to generate this email, so you will need to contact us. In the chat, Ashley will add a link to the education mailbox and what information is needed for us to send you a certificate. If you think of any questions, those can be mailed for up to 7 days following the event. That does bring us to the end of today's presentation. On behalf of myself, Ashley, and the Provider Outreach and Education team, I would like to thank you for being here today, and I hope that you will join us for future events.